Right. I believe that is our cue, Mandy. We go ahead and get started.
Absolutely.
All right, fantastic. Well, thanks for everyone for joining, and Ashley for organizing. So I guess I would go ahead and start off with an introduction of myself. My name is Mohammed Idris, recently new faculty in the Department of Medicine at the Morehouse School of Medicine. Um, Previously, before that, I finished a fellowship in environmental medicine and public health at the Icahn School of Medicine at Mount Sinai, New York City. And before that, spent quite a bit of time in industry as a data scientist, where my work kind of touched a lot of different areas. One of the areas being broadly social service delivery and healthcare. Really excited to be moderating this panel. We have kind of really top-notch folks joining us today, and really hoping to kind of get into the nitty gritty, both in terms of trends in the space around emerging technologies, digital health, AI and machine learning, but then also some of the challenges associated with kind of this new kind of this paradigm shift in how we're leveraging technology to kind of better our health. And so why don't I go ahead and start us off with some introductions. And so why don't we have our panelists, and Mandy, please feel free to start. Why don't you go ahead and introduce yourself, tell us a little bit about yourself. And in particular, I'm really interested in some of the exciting work you're going on. So maybe you could give us some insight on maybe an exciting project that you're working on.
Absolutely. And thank you for having me. Hello, everyone. My name is Mandy Long. I'm the Vice President and General Manager of IBM Watson Health Provider Analytics. I am a longtime health tech veteran. I've spent time at a lot of names that you guys are likely familiar with. I was with Epic for a long time, Experian Health. I was head of product at Modernizing Medicine, and then I've spent the past 3.5 years as part of IBM Watson Health, doing things ranging from running the medical imaging portfolio from a product and strategy standpoint to oncology and genomics, and then now I have the provider analytics business. I think one of the things that I've really enjoyed about the time that I've spent at IBM in the past 3 years, I feel like the timing was very good for the things that are happening in digital transformation and AI, because IBM in many ways is at the forefront of that, right? We're leaders in research, and we do an incredible amount of work in bleeding edge tech. And I think a lot of where I have seen really material progress, and one of the things that I'm excited to talk about today is I think we're starting to see some of the more, I think, far-reaching or complex models cross the threshold into production. Right? We're doing some really interesting things at Watson Health as a part of image analysis and supporting detection and characterization and classification, which is a sort of wild concept of 5 years ago, right? That now is, I think, getting more real, and we're doing a lot more with clinical data and natural language processing. So that's a little bit about me.
Amazing. Definitely a veteran in many ways. And also we have Fatima Paruk. Really nice to see you, Fatima. Also, I would say a veteran in the space. And so please feel free to tell us a little bit about yourself, your background, and some of the interesting work you're working on.
Thanks so much for having me. I'm Fatima Farouk. I'm a physician. I have a background both in clinical medicine and in public health. I'm super passionate about improving population health through big data research and outcomes research. I am currently the clinical director for clinical data and innovation at McKinsey, but prior to my short tenure at McKinsey, I've only been there about 8 months at this point, I was the chief medical information officer for Microsoft's US Health and Life Sciences business. And prior to that, I was the chief medical officer for analytics at Allscripts, which is an electronic health records company, where I ran a team of data scientists who basically did research and development around AI and machine learning, leveraging a lot of the big data sets that were out there. So I'm super passionate, just about this space. I call myself a self-proclaimed data dork, but I think what I am most excited about is just being able to live at this intersection of medicine, public health, and emerging technology. I think there is so much potential and so much rapid development that we're seeing right now that the potential is massive. So super excited. Thank you so much for having me.
Awesome. Thank you so much. And finally, but definitely not least, Dr. Mary Wang, who has been a leader in the space of biomedical research, health and bioinformatics, image analysis, has been really doing a lot of research on the cutting edge. So really excited to have you here as well, Dr. Wang. You want to introduce yourself really quickly, a little bit about your background and some of the work that your lab is currently working on?
Thank you, Mohammed, for your nice introduction. Also, thank GA Bio for inviting me to join this exciting panel. So I'm a full professor in the Joint Biomedical Engineer Department of Georgia Tech and Emory. I'm also affiliated with the Electrical and Computer Engineering at Georgia Tech. I'm a Georgia Tech alumni and also Tsinghua alumni. I work in industry the former Lucent Technology Biolabs for a few years, then was recruited back to be a professor at Georgia Tech now for close to 20 years. So my research has been focusing on biomedical, big data, and AI. So over the last 19 years, it has been a very exciting journey. We actually run one of the 8 national center on cancer nanotechnology by integrating cancer biology, the nanotechnology, and the AI, biocomputing for personalized oncology. Also, we have been dealing with some pediatric as well as aging population challenges ranging from neurological diseases like Alzheimer or traumatic brain injury to the chronic other conditions such as cancer, diabetes, as well as acute conditions in the cardiac ICU. So I'm very excited again to join my distinguished panelists to speak today. Thank you.
Thank you so much, Dr. Wang. Really excited to have you as well. So of course, I by no means would I consider myself an expert compared to you all and all the work that you've done over the past, several decades. But one of the things that I find most interesting is that there seems to be quite a few trends, right? Whether they be around technological innovation, whether they be around changes in the regulatory landscapes, cultural shifts in how people are interacting with technology when it comes to their health. And I'm curious, and maybe Mandy, we could start off with you. And really, I'm curious, this panel is about kind of the current trends, right? So is there maybe if you could talk a little bit about kind of the channels of care that you feel have been the most impacted by AI and machine learning, particularly over the last 12 months, because again, as I think about where we were 5 years ago or 10 years ago, it really has been a paradigm shift. So yeah, what are some of the kind of most impacted channels of care over the last 12 months?
So I think it's a great question to start with, because if you look at what's happened over the past 12 months, you've seen a dramatic shift in how patients are engaging and how care providers are delivering care. And I think, the most obvious one in front of you is telehealth. I mean, you literally saw something that prior to the pandemic, we were still struggling to get basic level reimbursement for. And it's now sort of one of the most common methods of interaction. There's actually, a level of channel mitigation that you need to go through to get an in-person visit still, right? Because hospitals are still struggling. There are certainly, we are not out of the woods. I talk about that with my team and other folks as well, as there are, certain parts of the country and certain parts of the world that are, very much still struggling. And so we have not emerged yet. However, I think what's happened in telehealth has been a really interesting example of the potential for technology and the really fine line that we're going to need to walk as it relates to, and I'll say the word again, channel management, because there's appropriate care associated with that. And there are times when a telemedicine visit is going to be absolutely awesome and nobody's going to want to sit in a waiting room anymore, and that's great and it's going to work. And there are going to be other times when we really are going to need to focus on getting the patient to the right location and the right provider in the right way. And I don't think we've crossed that threshold yet. I speak with a lot of health system executives who I think are going through that balance now. Is we had such an extreme shift when the pandemic hit, because we saw a massive drop off in chronic care management, preventative care. People just didn't want to come into the building. And so I think we went a little bit too far on the pendulum, and I'm not sure we've sort of hit the balance yet. But I wonder, Dr. Parukh, from your standpoint, if you're seeing similar things or anything different.
I'm going to respectfully disagree just a little bit. And usually I'm so gung-ho on the provider side and talking about that provider perspective. But I think, you brought up the COVID thing, right? And COVID has forced all of us to rethink everything we do, right? And so obviously that shift has been huge in telehealth and from the provider perspective. But I actually think that when you think about the consumer and the patient as the consumer, there's been a huge amount of shifting as well. So when you think about patients being matched to services, I feel like that has really, really taken off during our COVID time, where people were scrambling, looking for testing, scrambling, looking for vaccines. And all of that, had a huge potential to be algorithm driven, where you could actually manage that matching process between patient and provider and being able to seek care. And so I think that is one area that I've seen a heck of a lot of just, crazy improvement in a very short space of time. And I'd like to actually see if that is sustained. I think, again, the patient as the consumer is certainly more empowered coming out of COVID in terms of recognizing what services are actually out there and how they actually seek care. So I think that is certainly going to be something that sticks, and we'll just have to see where it sticks the most. But certainly I think there's the patient perspective there.
Excellent, and we always like to see kind of interaction between panelists as well. So I encourage it, disagree, agree. This is great. But that does bring up a great point, Dr. Parukh, right? So there was a Gartner report that says by 2023, 1 in 5 interactions will include some form of artificial intelligence or machine learning. That likely could be at point of care. And then also when we think about broadly, and I know these kind of frameworks have been developed mainly in the maternal health and maternal mortality space, but there's really kind of 3 areas where delays in, number 1, knowing that you need help, right? Number 2, once you know you need to help, being able to access care. And then the third one, mainly knowing where to go. And number 3, essentially once you get there, getting adequate care, right? So there really are kind of, I think, very well-defined areas where I think, as you're putting it, machine learning can play in terms of streamlining. And you're talking about it broadly. Can you point to maybe some specific examples, either at your work or examples that you've seen in industry where you have seen kind of these targeted interventions leveraging AI and machine learning in order to overcome some of these barriers?
Yeah, I'm happy to, just talk about maybe ones that are most important to me, just from a personal perspective. I mean, I'm incredibly passionate about reducing clinician burnout. So today, I've read even just a report this morning that basically said for every minute you spend in front of a patient, you're spending 2 minutes documenting in the EHR. What if we could actually make these solutions smarter and make them work for us, right? So when you are dealing with your patient, in the 5 or 10 minutes that you actually have to have a reasonable conversation with them, how is the technology working for you to reduce your level of burnout and your level of work? And so one particular area this might be incredibly cool to see is in the area of clinical decision support, where the machine would essentially take into account all the available information about a patient that is relevant and in context, combine that with any of their social determinants of health or relevant information about them from the community, in addition to provider practice patterns, and then come up with the best form or the best algorithm to drive treatment plans that they are going to be best fit with, that will drive the best possible outcome and drive the best possible compliance for the patient who is, again, just trying to understand their treatment plan. So I think there is a huge role for AI and ML as it relates to clinical decision support. And I'd love to see that take off in the next, couple of years here in the short term. I understand there's some policy limitations to the way that really works, but in theory, I think the potential for that is huge. And I'd like to get Mandy's and May's perspective on this as well, in terms of where they're thinking about the biggest possible bang for people's buck.
I mean, I don't disagree with what you said at all. I think that the potential for clinical decision support is extraordinary. I think one of the things that I think we haven't sorted through how to accelerate the release of that technology into the wild, because depending on where you are in the world, you can be a class 2 medical device, and there can be extreme rigor associated with how to get things out there, right, that could have the potential for impact. And obviously, I think you can do it under a clinical study. There are plenty of ways to test it, but I think I'm not sure we haven't hit our stride yet, because I think we're still working through some of the mechanics of even just sort of creating predicates that can be followed through agency clearance. But I do think, without question, right, regardless of whether you're talking about image analysis, clinical decision support to support a complex MRI, interpretation, or doing contextual summarization of the EHR and being able to lean into, best practices and the protocols that are out there to shore up, and reduce the amount of time that a clinician needs to spend in PDF land. I without question, that's the place.
Definitely. And I think it's actually a perfect segue to maybe some of the work that you've been working on, Dr. Wang. And I'm curious, kind of broadly, some of the work that you've been doing around kind of regulation, sharing IP, so on and so forth. But also there kind of always seems to be whether it be specific to healthcare or outside of it, when we talk about AI and machine learning, it's always this idea of black box algorithms, right? In particular, when we're thinking about leveraging some of these tools for clinical decision support, right? What are some of the medical, legal, ethical questions that you feel we're just now getting a handle on kind of within the research and development space that have not yet made it out into kind of everyday clinical practice?
A very good question. In fact, it's all related. When Mindy and Fatima were talking about what can be utilized now, I actually immediately thought about, besides the point of care, the real translation front, there are also the fundamental infrastructure front. So that's actually, to me, there are three things are emerging related to your first question. Then I'm going to comment about this ethics. So the first thing is data harmonization. Don't you agree right now this is a major issue? You have different healthcare system, you take care of the patient, the data all completely sitting in silos, right? So that's why the major I would consider accomplishment over the last 12 months is CMS and VA and right now even Google, in addition to Cerner and Epic, start adopting the new HL7 standard called the FHIR, Fast Health Interoperability Resources. So right now, a lot of hospitals start using it. It's going to take a while for us to see it, but that's actually a major infrastructure related. Second one is related to what you just said, Mohammed, what's going on beyond this if we start talking about adopting AI. So I can share with you, because I started my college life in the last wave of AI. That's why all these years I work on AI. Why the last wave died out, right? Silent for so many years. Why it's only recently became active again? Fundamental reason is lack of successful stories. Something AI really are the key technology help transform the society, right? So that's why in this wave, when the wave started, that's what everyone's looking for right now. And when we're looking at that right now, there are 5 grand challenges. I'll talk about other challenges when you raise another question. But here, I just want to mention one thing related to this particular challenge of regularized AI. So how FDA can approve AI algorithm, which happen to misdiagnose the patient, to kill the patient? Who is responsible for that? So that's why, like the data harmonization, that's called the data standard, right? Right now, we need to start looking into the AI algorithm model standard. So that's what's the current, another emerging theme going on, starting with the US FDA, also right now is vividly pursued in both Europe and Asia, is looking into the model and AI algorithm for standard. So we can actually regulate this, right? Because it's a black box, how do you know what's happening, right? And then in addition to that, you also talk about what's happening the last 12 months. That's actually, besides the telemedicine, I totally agree. COVID pushed telemedicine in the front. If you look at my website, 20 years ago when I joined Georgia Tech and Emory, the BME, I put telemedicine as one of my research areas because I came from communication industry, right? Unfortunately, no progress. I tried to push this idea all these years, but last year something overnight started happening, right? But on top of this, in addition to this kind of push, there's another one which actually is more widely adopted right now, is adopting it into the radiology. The radiology will be leading the way ahead of pathology. Pathology would be the next one. Okay, so that's related to your first question. Now coming back to this issue of regularization. So FDA had a task force right now. FDA even have formed a new center looking into this. So one of the first question, besides the technology issue, so is ethics. Who owns the data? Who owns the model? Who actually can control to change the model, right? I work on AI for 30 years now. We all know that AI algorithm, depending on, very critically depending on what? Depending on 3 things, we call it. 1, the application angle, right? You want to go for sensitivity, you want to go for specificity diagnosis, go different, it's going to be different. Second one, it's actually heavily dependent on the data prevalence, right? You have a rare diseases versus a high prevalent diseases. That's how it's related, right? The third one, it heavily related to your local cohort. You are going to have embedded bias. You have a different data model will customize to that data. That's going to be biased, right? All these issues. If you say who owns the data, if the model is owned by a particular developer, data owned by a particular patient, how FDA is going to regulate this? So that's the upfront, this ethic issue. And then beyond that, then there are all these technical challenges. So the challenges include that we have been asked by FDA look into next gene sequencing when the precision medicine initiative started in the US. So for next gene sequencing alone, for Illumina technology, there are 217,000 parameters combination. When you're actually trying to come out to decide which actually the marker might be serving as a goal for doing the cancer diagnosis, right? So when you change the parameter, we have shown with FDA together, changing one parameter alone, you completely change the result, opposite to the real clinical trial results. This is very dangerous, right? Who is going to be liable? So that's probably the reason why, like Dr. Parekh, you probably won't trust the AI, right? If the AI kill the patient, you don't want to be responsible, right? So,
not true.
So I'm just saying that's actually one of the major issues. So that's why on the technical front, under the standardization, we're actually now talking about several possibilities. The possibility is how do we do explainable AI and interpretable AI? These are two different things. First, explain the black box to a physician. Second one, for the physician to be able to interpret. And then another thing is how do we actually do remove the bias when you collect the data, training your model. Third one, how do you develop a model without like compromise the privacy of the data? So how do you do that? So all these are on the other front, the technical front, the ethic front and technical front. We both now needed to investigate what are the standards for the AI.
Definitely. So thank you so much. And I like how you put that. There's multidimensional, right? There's a variety of different issues at different levels that we need to grapple with. And so one of the maybe I could pass it over to you, to Dr. Parukh, of course, this idea of whether or not you would trust it, I am curious your thoughts. I think you might have some strong feelings there, but also thinking of it this way, where, at the end of the day, as was said, right, it really comes down to kind of the quality and the availability of the training data, right, the problems that you're focusing on, right, and so that's always a big component of it. And I'm curious in some of your work how some of those issues are dealt with.
Yeah, I think firstly, the availability and the quality of the data is huge, right? So it comes down to, again, being able to have some level of transparency around what data was utilized for the training algorithms as you create such algorithms, right? So that's, I know that, a lot of the innovation has been done on the industry side, right? And so therefore, there is a lot of protection around what data was utilized, and there's almost a caginess and a lack of ability sometimes to share some of that stuff. But I do think that there are steps that those who are in this space of creation of the algorithms with the training data can be transparent to some degree on what types of data was actually utilized. I think this data or the algorithms then have to be reproducible in additional data sets. So I mean, it's once it's deployed and making sure that if this stuff is put in the different environments and different populations, we can see where the failures are and where algorithms need to be adjusted or refined. But I do think that there's a lot to be said from a clinical perspective, especially if you're utilizing these clinical algorithms to make treatment decisions, that this stuff has to absolutely be transparent. And once you can show that level of transparency in terms of maybe what are the features that went into the algorithm that are helping to drive some of these decisions. That's how you get the clinicians on board, because the clinicians are not actually resistant to leveraging new technology. They just want to understand how it works. And so I think as long as there's that level of transparency there, and then also this level of accountability, right? Because the reality is clinicians at the end of the day are held accountable for every single treatment decision that's made. There's no way today that you can say, oh, well, the algorithm said I should do that, and that's why I did it. And you would be, let off in a court of law for malpractice. I mean, that's just absolutely not going to happen. So the more transparent you can actually be in terms of figuring out what that implementation looks like, so the clinician is still empowered to make their decision based off of the available data, I think the better off you are. So those are a couple of the things that I think about. And then, just one more point on that transparency piece. I mean, we know about the potential for bias, and that has a lot to do, again, with the way that the training data is generated. I mean, if you're looking at electronic health records data and, those that are in the systems, generally speaking, we are not going to have as much data or as much high quality data on populations that have been marginalized or, are just, again, not as healthy perhaps as the rest of the population that actually do need the most amount of help. And so I think we have a responsibility in the space to do what we can do to overcome bias and to ensure inclusivity as we think about development of algorithms that will benefit healthcare populations.
I couldn't have said it better, and that's obviously something that we think is top of mind for us at the Morehouse School of Medicine, right? And Mandy, I didn't mean to cut you off, but that's a perfect segue in our prep for this panel. This is actually one of the things that you mentioned, right? This idea of how do we deal with issues around bias and race and equity. That's something we're struggling to grapple with as a society, let alone kind of within the industry, right? And so I'm curious, as Dr. Parukh mentioned, it really is. Industry leaders like IBM who are at the forefront of kind of pushing the limit as to where we are. And I'm curious how it could be particular to your team or just broadly at IBM, how you think about these issues, and how is it that you're trying to provide this transparency? Are there any advancements around explainable AI, around privacy protecting algorithms? Another thing that came to mind as Dr. Parukh was mentioning, this idea of being transparent about what training data was used, the idea of using kind of the I believe they're called scorecards, in terms of research scorecards where while they're publishing the papers, it's also pretty transparent as to what went into training, if that's something that's being considered. So please.
Yeah, and I apologize. I think I lost you for a second, but I think I heard most of the questions. But I mean, the topic without question is one that's critical, and it's one of the many reasons that I'm proud to be an IBMer, as I think our CEO has come out very strongly about the role that technology organizations play in overcoming some of the bias that exists in the development of these models and the release of them. And I think from a Watson Health standpoint and organizationally, we put it out in the front. So when we talk about, and there's sort of a couple of threads I'm going to pull together as an example here, right? I think, Fatima, you talked about this idea that you have to have stratified data sets and you have to be able to pull from the areas that maybe don't get the level of representation that they deserve. And it's something that we put together when we work with our collaborative members. We have a lot of hospitals and health systems who partner with us, where we're really deliberately looking at risk of bias and how we think about doing data and training. And I would add as well that I don't think it's just about the quality and diversity of the data sets that you're getting. I think there's also a really important nuance around annotation, because you can have really fabulous data sets, and if they're improperly annotated at a local or a global level, you can still get really poor results. The other thing that I wanted to kind of come back to that Dr. Parukh, you said was, I think one of the things you noted about clinician trust associated with models, right, and the kind of willingness to adopt this technology. I think there's a really important nuance to what you said that is the very aggressive cat. That I think is the key to how we're going to see commercialization and adoption of this. Absolutely, explainability, transparency wherever possible is crucial. But what you talked about, there's decision support, right? I think we originally came out of the gate, 5, 6, 7, 8, 10 years ago, talking about this idea of autonomous AI. And I think that's, I mean, we're nowhere near, like, that's a fallacy, right? There's a human component to every decision that's made. And I think that the sooner we can just holistically accept that as technologists, it's our role to support a clinician in practicing at the top of their degree and and seeing the patient, like, then I think we're going to see it fly. And that's, I just wanted to make that note, because I think it is so important for us to drop this idea that we're going to replace, it's not true, right? It's not true.
Yeah, even if we were at a place where we could do it, is that the right thing to do, right? Technology is an enabler as it's meant to be, not necessarily the solution. Dr. Wang, I'd love to hear some of your thoughts. I know some of your work focuses on kind of AI and machine learning broadly with older populations, right? I think one of the things that's often overlooked is that while in some ways digital health innovations can actually kind of address health disparities, if they are actually not equitably distributed, it could actually in many ways exacerbate health disparities. I know that's a core component of my research. So I was wondering if you could speak a little bit to kind of what does the future of healthcare or AI and machine learning look like for populations who are a lot less tech savvy, and some of your work around that.
Oh, I see. Okay. But I want to again try to comment one more thing for
please.
what Fatima and Mandy just mentioned. So first of all, this is a clinical decision support, okay? So it is meant to be supported rather than replaced. So I totally agree with Mandy. And second of all, Fatima, I'm so thrilled to have a physician like you who trusts the AI. I'm actually in the American Board for AI Medicine. This is a largely clinician society. I'm one of the data scientists being invited to serve in the board as well as to teach. Right now, every month we certify physicians for AI. Largely for one thing related to what you just said about transparency. That's why I want to quickly mention that. I think we want to go to meet in the middle, in the sense that when I have a lot of my own students coming from medical school, right? They have a biology background. When I initially talking about AI neural network, that's way over their head. They don't even understand what the sigmoid function is for, why we need that. They also got confused. The logistic regression is a classification algorithm. They think it's just like a linear regression, which is completely and not there. So that's the reason why I think a part of the thing to adopt the AI to make it transparent, in fact, is education. I think education should be patient education, and also it should be a provider education, should be insurance education, right? All these user education. So how do we deliver AI to their space, make them adopt, understand? By getting at least the basic terminology, there's a chance they can understand the AI algorithm. In addition to that, we also right now are being advised by our advisory board that they think we should educate the old health system, the chief executive officer, because if they understand this is important, they are going to encourage their physicians to go ahead, get board certificate, go ahead and get some education, right? So, give them time, give them support to do that. So I do want to also mention about this. I feel like that's probably what's needed when we eventually have a clinical decision support designed by computational expert with medical knowledge. But meanwhile, importantly, for the medical expert who understand some terminology of AI. So then we meet there's a chance we can make it happen. Now, coming back talking about how do we address the disparity issue. So for a long time, people think about it. What is big data? What is AI? They only thinking about is the big population, because more than 90% of study ever since the 1960s, is more than half a century, are based on correlation-based study. It's not based on how real physician doing inference, right? The causal inference. It's actually partially because from pure technology perspective, from computing perspective, it's an NP hard problem. We are trying to got all the possible causes of any potential outcome, right? So that's one of the reasons why they're less than 10% over all these years in modeling this. So that's why people started building a misconception here. Thinking about anytime we're talking about AI, it must be N is millions, okay? N greater than 1. But in reality, right now, we need to also address the personalized medicine, right? Individualize the care. So really come back to n equal 1. So that's why the real current, the emerging trend right now for AI is for population. AI also has to go for n equal 1. But for n equal 1, you are talking about a multi-modality, many things about the person rather than one thing. You can have a feedback. You can, if aging population in the senior home, we like we installed the ambient sensor, right? Fall detection, the toilet flushing, to see whether the person has any regular digestive action. Mirror has a blood pressure, temperature measure. Anytime when go to the bathroom, wash hand, there's a check, right? So all these things, ambient sensor plus some wearable sensor on the hand, in the body, right? Together, you're going to start getting a multi-facet, multi-modality information, even about one person. Then you start computing some kind of profile about the person. And then when the person has some episode for aging population, we're instead traditionally looking at a big population, right? Big group comparing. Now we're actually doing a personalized normal condition versus like a abnormal condition. You build the metric, the baseline based on this person, and you start comparing against this person in the process. So that's actually one of the area right now is getting more attention now. And also this particular area started extending to the rare diseases beyond just the population, the senior population started. Also, it goes to junior. As I mentioned, I work on both the aging population as well as the pediatric, the two end. So we do the same for kids. For example, the kids with heart transplant, right? You don't have a large population, but it's very important to monitor the kids for potential rejection, any potential issue. You do the same, right? It's n equal 1 or maybe n equal 10, very small number. But you build a norm of the person and then detect the abnorm. So that's one of the directions going on right now.
That's fantastic. And of course, as we see kind of the proliferation of all, Internet of Things, of devices, sensors, wearables, that also has, beyond just a health record, right, is a massive source of data that is constantly being accumulated. And one of the things that I came across, and I'm sure many people have been speaking about this, but, of course, as we accumulate more and more data in these, single places, right? I think consider what they call it, a honeypot or something like that, right? It becomes more and more valuable, right? So now we have to start thinking about things around infrastructure and security and things like that. I'm, on the East Coast, there was the recent ransomware attack, right? Where we've seen how overnight one decision can really have an effect kind of broadly. And then we could even tie that back to concerns around privacy and trust. I would imagine, as most people, breach in security leads to a lack of trust in the organization, in the infrastructure, and ultimately in the use of the technology or who I'm giving my data to. And so I'm wondering, Dr. Parukh, if you could speak to that a little bit. What can or should healthcare organizations, if somebody was to come to you at McKinsey and say, listen, we're really afraid, what's going on? What are the sort of questions you would ask? What are the sort of recommendations that you would provide? And what is kind of, at some point, what is the state of the art? Are we in a place where we are 100%, able to deal with the current landscape of cybersecurity threats?
Yeah, I'm certainly not a cybersecurity expert, so I'm going to disclaimer with that. I think some of the other folks on the call might actually have a much better perspective, but I can talk about, wide sort of concepts that I think are incredibly important. Again, we have to remember that patients must own their data and they must be in control of their data. So this idea that, patients are empowered to understand where their data is stored, how it is being utilized, and actually have, the power to deny unauthorized uses of their data should be front and center. Again, it's a patient right. It's a privacy concern that's across the field right now, and there has been much more focus on this recently. But certainly, the patient, deserves to own their data and own exactly how it is utilized for secondary, tertiary purposes. The second thing is, as it relates to hospital health systems, information systems, I think there are minimum standards that are certainly published and in place. There has been currently, maybe less rapid investment in cybersecurity than I would have liked to have seen across the industry. But I think certainly this has been highlighted, and as you mentioned, right, in recent ransomware attacks that have happened where hospitals, health systems have been faced with these kinds of challenges very specifically. And so I do think that folks are making the investments. I think the other thing that has largely not been covered is also the fact that, we are giving away data rights in everything we do on a day-to-day basis. I mean, I will argue that, my iPhone and, just utilizing my credit cards, my credit card company probably knows more about my health than my doctor does, right? Because you would know my spending habits, where I've eaten in the last week. And I'm the first one to say that probably, I've not made the most healthy choices in terms of my diet. Or my transportation choices, where, again, so this data is out there. It's certainly floating around, and there's very little protection around that. And so I think it's not just hospitals and health systems that need to be cleaned up in terms of how we protect consumer and patient data from that perspective, but I think there is all this additional data that's out there that is not necessarily being appropriately protected. During the initial wake of COVID, I remember seeing this really interesting map of all the folks that had gone down to Florida for spring break, and then looking at their travel patterns to see where they went to afterwards, and how the spread of COVID-19 happened because people were literally traveling post spring break last year. And so again, that was all made off of publicly available data that had nothing to do with healthcare data. And yet from a public health decision-making perspective, and from highlighting, the problem that was associated with the COVID-19 spread, I thought that was very, very interesting. So there's a heck of a lot of publicly available, privately generated data that is not healthcare, that is certainly out there, that we really should be thinking about how we balance public health and safety with privacy of consumers.
Well said. Thank you so much. All right, so it looks like we're about up for the panel. So maybe I could close this out with a question for each of you. Concisely as you could make it, just given the time constraints. But Mandy, I'll go ahead and I'll start with you. Your background's interesting in that you have a background as an entrepreneur. You're working within this very large behemoth of a research and development organization, really at the cutting edge of all things machine learning and AI in healthcare. And so if you were to start a health tech startup today, or I don't know if you're allowed to answer that question, but in broad terms, or challenges that you see, what would you focus on and why?
Well, I've never always followed the rules, so I'll answer regardless of whether I'm supposed to. I think, there is an incredible amount of opportunity in this space. I think one of the things, so my answer is going to be, I think more of a kind of a personal passion than anything, is I think Dr. Parikh, you touched on this, like the idea of an individual's health is a heck of a lot broader than what happens in the exam room. And I think one of the things that is a really underrepresented problem, we started to see some regulation around it, but certainly not enough, is the impact of medical debt and the impact of the financial burden of care, particularly unexpected care, on the population, and how that influences their willingness to engage in preventative care. Like medical debt is the leading cause of bankruptcy. And I think there's a huge opportunity for AI and automation to get in front of that problem and start to because there are a ton of programs available, but there's this lack of connection with a cottage industry that is dealing with this problem. So I maybe went left on you, but I think there's huge digital opportunity for changing the way that the payment system works and how patients are sometimes caught in the middle.
That's amazing. It actually reminds me of, and I know I said keep it concise and I'm going off on tangents here, forgive me, but it reminds me of a good friend of mine, Jeannie Pinder, who runs an organization called Real Clear Health Costs. And so this idea that, the cost of blood tests can be, tenfold down the street, right? And so providing transparency around that, could very well lower that barrier to access. So I love it. Maybe I can move over to Dr. Wang. So of course you are at the cutting edge of all things around kind of regulating and some of these ethical, technical questions. And so I'm curious, if there was one take, there's a lot we covered in this panel. If there was one takeaway you'd want folks to take away from this panel, what would be probably the most important thing for them to take away?
So I want to share with everyone what are the 5 grand challenges and opportunities of biomedical AI. The first one is the data quality, garbage in, garbage out. Never forget this. So when we actually do any AI, the first thing we need to check the data quality. Currently, the medical error is the number 3 cause for death in the US. It's actually just after cardiovascular and cancer. That's very bad. So we need to really be careful on data. Second one is data integration. Currently, people always believe, like a marriage, people hope 1 + 1 greater than 2. In reality, it's not always true. In fact, in terms of data multimodality integration, even though I share with you early on for n = 1, you need AI. In reality, sometimes it's actually creating more confusion to clinician than bring clarity. So that's why multimodality sometimes may actually lead to opposite result. That's the grand challenge and opportunity. Number 3 is the one I also mentioned, the causal inference modeling. We need to actually go beyond the correlation-based AI algorithm development, start developing into an AI that's can do the cause effect, the causal inference modeling. This is very challenging, but ultimately this will be the one make the system more reliable. The fourth one is the real-time decision making. Pandemic taught us all a lesson, right? So when we actually talking about AI developed model, that's like teaching a kid. You are using your knowledge to help the kid build a knowledge base. So you can train the model based on many past samples, right? Retrospectively, you train the model. But going forward, the kids growing up need to make a decision, right? So there's real-time decision-making step there. That's where we need to correct the bias. If this model is trained, for example, in Wuhan, right, when this pandemic started, very quickly people realize that model cannot be directly applied to the data here, right? You need to use that knowledge, but you need to do a real-time model adjustment for your current data. The last one is the one we have already discussed. That's related to performance metric and usability of our AI model. So that's require us to be very clear about our metric first. I find out this is one thing that's very confusing. Using pandemic as an example, when you use testing, you care about the sensitivity. When you're actually talking about whether to allocate ICU for the severe patient, you care about the specificity, right? Precision staging. So metric play a role. In addition to that, the explainable AI and the interval AI play a critical role because physicians need to make a decision. They must first understand what the model provides them so they can actually make an adequate decision. That's ultimately going to lead to the real impact. So that's one thing I want to leave our audience with. Knowing that AI will provide potentially enormous opportunities. Meanwhile, there are still grand challenges. So we need more people from all angles to start working on this. And we need more education, more policy maker to be part of the process, and need more people in the standard. Thank you.
Well said, Dr. Wang. Thank you. And I guess we can close it out with Dr. Parukh. I'm curious, we talked about how 5 years ago there were things that we probably would have never imagined we can do in terms of AI and machine learning applied to healthcare. What is your, how do you see the next year, a couple of years looking like?
Yeah, I think that's really interesting, especially even just thinking about it again from more of a health tech startup perspective. Where would I go over the next couple of years, and where do I think the promise is? I think, one of the things that I do is I sit on the board of Prime Health Colorado, which is a not-for-profit that is empowering startups to bring digital health innovation to safety net organizations, for example. I think that, the time is now. Everybody has a responsibility to do stuff. The technology is there. You do not have to be an expert in data science or technology to actually come up with these brilliant ideas. And I realize that I personally am not the future. It's about all the younger, cooler people out there that have these amazing ideas. And if we can figure out as a group, right, with our experience, how to empower folks to bring their ideas from their communities that are going to make a difference to the main stage to improve the health of those who actually need it the most, let's figure out how to make that happen. And so that's what I'm incredibly excited about. Again, it's not me, it's not us, it's actually the next generation of ideas. And again, you don't have to be the expert, you don't have to have a ridiculous amount of funding. The tools are there, the technology is there, you just have to figure out how to leverage it and bring your ideas to fruition. So
Amazing.
that's what I'll leave that.
And I hope I qualify as being, the next generation as well. So I'm just going to throw that out there. Thank you all so much. I guess now, so we have a little bit of time left for attendees. If they had any questions that they would like to ask the panelists, feel free to unmute yourself. I believe folks should be able to, or send a chat message with a question. I could go ahead and I can ask that as well. It's always interesting with these Zoom webinars, right? I feel like we're in back-to-back meetings. And so it's always interesting. As a teacher, they always say, always keep quiet until somebody asks a question. But looks like we have no questions either on Zoom or Slido. So why don't we go ahead and wrap up here? I want to thank you all so much for taking the time. I know it's been hectic for each of us individually, but I've definitely learned a lot. And I look forward to following up with each of you individually. And I really appreciate your perspective and your expertise. And Dr. Wang, as soon as I make it down to Atlanta, hopefully our paths will cross as well.
Yes, definitely. I used to be Atlanta CTSA.
Okay.
The Morehouse colleague.
Yeah, Dr. O'Feely.
Yes. And also, Fatima, you mentioned about the burnout, 1 minute seeing patient, 2 minutes spent on the EHR. So actually the JAMA deputy EIC, I invited him to give a keynote in our conference. That's the number one thing he said. He said, why it used to take us 2 checkpoints, now I need a 17 step using EHR to do it. So I know this is a grand challenge. Part of the reason is I think we need another bio Google, right? To develop a disruptive, transformative technology. Otherwise, Epic and the Cerner, they're in tight control. They didn't want anyone to intercept with their workflow. So I would definitely love to have a chance to invite you also to come to talk. And then for Mindy, for the IBM, so honestly, I was hoping more health system will adopt Watson. So what's the current new strategic direction now? Like that's what I was waiting for. I think after the chess, I was waiting for the next one is in the healthcare. So what's the current the IBM's new direction on this?
So I think one of the things that's been interesting is, without question, right? And I've been a part of IBM for about 3 years, but I think, the marketing was really good a long time ago. We were, out ahead in terms of thought leadership. I think, the technology was challenging, right? And it is challenging. We've actually seen an incredible amount of adoption. We have thousands of customers across government, health and human services, payer, employer. So it's a multifaceted portfolio that I think is actually, I'm not sure that everyone's aware of it. I think that's one of the things that we kind of got, I think we went really loud and then we became really quiet. But there's some really extraordinary stuff that's actually going through agency clearance right now related to things like image analysis. And, that's going to be setting the threshold, right? We're looking at like liver, prostate cancer, doing some really, I think, interesting things. And I meant what I said about detection. That's going to be a big bar. And we're in flight on that. And so there's some stuff coming, but I would say for sure, we're actively engaged. We use Watson in a variety of different ways, everything from sort of chatbot-based stuff to RPA to, we have a degree of clinical decision support out there, contextual summarization, which Fatima, you and I should talk about because, man, there's so much opportunity. But I think that, we're there, right? I think we now have to, we got to be a little bit louder about the victories we've had, because just because they're small doesn't mean they're not meaningful, because they're going to, momentum begins with the first.
Wonderful. Yeah. And also, I think from our panel, I can clearly tell, like, just four of us together, we can actually make some real impact. Small project. I actually have been thinking about maybe starting with the disparity. What do you think? Pick up that and then looking at all aspect of that, right? Maybe starting from us, we can have a small successful story.
Yeah, no, definitely. It actually, Dr. Wang, you mentioning that, it reminds me of some work that we're doing right now where we're looking at multi-level interventions where you would have interventions at the individual level, right, at the patient level. Of course, you would need to address certain, structural barriers at the patient care team level as well, right? And we've spoken about that as well. But then it also goes up to the system. And then from that, leveraging also resources within the community. One of the things that I've been thinking a lot about before coming to Morehouse is how is it that we can kind of leverage community broadly defined, right, in order to identify problems and train the algorithms that, if anything, can point people towards resources that are available outside of the healthcare system, right? We know that a lot of things, so yeah, no, I think there's a prime opportunity, and I'd love to explore that.
Yeah, and then as I mentioned that right now there are a lot of push also from the clinical community. So that's why besides the American Medical Informatics Association, which used to be the prime organization for all the physicians, right now there's this AMMed, right? That's a new organization focusing on finding out opportunities. And then I think another thing is Fatima mentioned about young generation. Mohammed, you are young generation. So I think it's part of also the paradigm shift in terms of education, right? We want to grow up to be, for example, for me, I really want to be knowing more medical knowledge, right? And then for a lot of physicians, they probably want to be the one knowing the computational terminology, right? Throughout their education, then as a part of their curriculum. So that's where I also think that that's another area. One is health disparity. The other one is probably in terms of education. Right? I definitely feel like it's a great composition of our panel if we combine our strengths together.
Fantastic. Dr. Parikh?
Hi, everyone. I'm so sorry to interrupt. Thank you all so much for the wonderful discussion. We do have to wrap up as our keynote is about to start here in about 1 minute.
Thank you very much.
Thank you,
Thanks, everybody.
everyone.
Thanks so much for having us.